When performing forward scoot, make sure you monitor the patient's trunk and provide lateral weight shift for those who may not have trunk control. Scooting a patient backwards, again, you need to keep in mind of shifting the patient's weight to the appropriate side in order to get the hip back to the appropriate position. When scooting a patient to the side of the bed, make sure you have the patient use the appropriate mechanics by leaning forward and helping the patient lifting up their rear. Notice the therapist's rear. When performing sit to stand, remember to ask the patient to do as much as they can on their own. Here the therapist is providing minimal assistance, trying to stay out of the patient's personal space. When providing moderate assistance for sit to stand, the therapist gives a little bit more assistance in the rear and can actually help with getting the patient's chest in the right position. The gait belt can be grabbed several different ways to assist. You want to make sure that you're out of the way of the patient so the patient can use the upper extremities as needed. For maximum assistance, make sure that the patient is scooted towards the edge of the bed. Weight shift. Your hands will be under the patient's ischial tuberosity and the patient's to lean forward. Stability is provided at the low back and or the gait belt, and again the ischial tuberosity. For a min assist stand pivot transfer, make sure the wheelchair is locked in an appropriate place. Again, ask the patient to do as much as they can on their own. Provide instructions. The patient should lift with their arms. Again, min assist is more for a balance. The patient reaches back and the patient is lowered to the chair. Moderate assistance, again the therapist is reaching from behind. Note the body mechanics. There's a balance assist. Have the patient reach back and seated. Keep in mind you can use a walker. A maximum stand pivot transfer can be performed several different ways. First, you want to angle the wheelchair as close to the patient as possible to minimize the distance needed to travel. The patient's feet need to be directed in the correct position and direction. Again, provide weight shift, reaching for the ischial tuberosity, the low back end or gait belt. The patient stands, weight shift is provided, and the patient is seated. When attempting a maximum stand pivot transfer, first the patient has to be able to stand fully. If the patient is unable to stand fully, the transfer can be aborted and another method can be used. When a patient's unable to do a full stand pivot transfer with max assist, the therapist can use a modified stand pivot transfer. Here, the patient will not stand fully erect and the therapist is providing maximal or dependent lift. Again, note the mechanics of the patient and the therapist's rear. For a sliding board transfer, the board goes underneath the patient's thigh, not the rear. The board is secure in place. Directions are given to the patient to use their upper extremity to lean forward, and the therapist provides assistance as needed. The patient shifted laterally to bring out the board to avoid skin abrasions. For a patient who requires a dependent transfer, for example, a spinal cord injury, the therapist will lean down low to get their center of gravity in the appropriate position. The patient is leaning over the therapist, and the modified stand pivot transfer is provided. It's always good to have assist of a second person. Keep in mind that patients typically do better when they have an assisted device to help with the transfers. It makes the transfer easier and more independent for the patient and easier for the physical therapist. Here the therapist is providing a minimum stand pivot transfer with the use of a walker, giving instructions and walker management. For a modified stand pivot transfer with a walker, the therapist may provide more verbal cues, a little bit more assistance physically to the patient, perhaps a little bit more assistance with the walker. The therapist for a mod assist transfer is providing up to 60% of the workload for the patient. When gait training with a walker, the physical therapist needs to make sure they give the patient appropriate cues. Here the patient is to be weight bearing as tolerated, which means the patient can place as much weight as they can in the lower extremity. Keep in mind the mechanics of the walker, the height of the walker. Some patients with min assist may need assist just for balance. Some patients may need a little assistance with the walker itself. Note here the patient is placing less weight on the right lower extremity, as instructed by the physician. For touchdown weight bearing or toe touch weight bearing, the verbal cues given to the patient are typically to only put 10% of their weight on the lower extremity. Even for toe touch, it's important to have the whole foot placed flat on the ground. When performing non-weight bearing, it's important that the patient advances the walker in the appropriate distance, not too far, then they wouldn't have the appropriate mechanics to help with the non-weight bearing status. When performing gait training for a patient who has balance deficits, keep in mind that the patient may need assistance for walker management and for balance. Note where the therapist is, slightly behind and to the side of the patient. If the patient's gait becomes out of control, the therapist can stop, regroup, and then continue on. Here the patient loses their balance, but the therapist is prepared to catch the patient. Stop, regroup. Hemi walkers are typically used for patients who have suffered a CVA and have hemiparesis or hemiplegia. The therapist needs to provide detailed instructions when using the hemi walker and to maintain a wide base of support. Here the therapist is providing minimal assistance, advancing the affected lower extremity. Note how the therapist is helping the patient advance their left lower extremity, also providing weight shift to the left. Here the physical therapist is providing more of a moderate assistance with the left lower extremity. Notice how the therapist can actually block the left lower extremity in order to prevent buckling. Again, paying attention to the chest wall, keeping the chest up. This is not extremely functional gait, however, it's the start. Keep in mind when providing crutch training that just because someone's young or athletic does not mean they have the coordination or ability to use crutches. Here is typically what happens when patients do not know how to use crutches and the crutches slip out from their arms. If crutches don't work, you could always use a walker to begin mobilizing the patient until they become more coordinated.